Well, thank you for that kind introduction. It's an honor to be here. My primary disclosure is I'm not an interventional cardiologist. I'm a vascular medicine and preventive cardiologist, but I hope to convince you in the next few minutes that measuring and treating LDL and LPA are potent coronary interventions and critical adjuncts to catheters and stents in treating our patients with complex coronary disease. So for many of us, the PROVE-IT trial was an inflection point in thinking about lipid management for coronary disease. You know, back in the old days, lipid management was an endocrine issue, and now it is very much a cardiology issue. And PROVE-IT established high-intensity statins, LDL of 70 milligrams per deciliter. In fact, it was a very effective intervention, but the bad news is that 1 in 4 patients at about 2.5 years had a recurrent event or died of cardiovascular causes. And you're hearing about all of the orthogonal pathways of risk, inflammation, obesity, and so on that contribute to this, but a lot of this is untreated lipid risk. And since PROVE-IT, which is sort of in the middle of this slide, there have been a series of studies that have shown us very clearly that lowest is best in terms of LDL cholesterol. One of those pivotal trials was FOURIER, which looked at a monoclonal antibody to the chaperone protein PCSK9. In essence, it increases the density of LDL receptors on the surface of the liver, so you suck out more bad cholesterol and excrete it. And even over a short period of time, lowering LDL from 90 to 30 reduced cardiovascular risk by about 15%. I think equally important observation from FOURIER was that a lot of patients got to LDLs in the blue or the purple here, less than 50 milligrams per deciliter, or even less than 20, and there was no signal for adverse effects. In fact, there was a nested neurocognitive study called Ebbinghaus, which showed no impact on neurocognitive function, so it was safe. But like many people, you know, we've got a lot of drugs out there, and the question was, who should you treat? Who's going to benefit the most? And because we're at the Complex Coronary Conference here, I thought I'd pull some of the subgroup data for coronary intervention. And what you can see easily on these slides from FOURIER is that the patients that you see that undergo PCI are amongst the highest risk. You can see in the solid curves, higher risk and even greater benefit of LDL lowering. And on the right side of the slide, for preventing the next heart attack or coronary heart death, there's an interaction, significantly greater benefit in those patients. In fact, when you look at why they come back for their next coronary intervention, here all of the recurrent coronary events in the trial, you can see that there's a consistent benefit across all of them. And if you look towards the right side at complex PCIs, they're coming back for their next complex intervention, there was a more than 30% reduction. So the adjunct of PCSK9 inhibition with the coronary intervention, from intervention to prevention, as Dr. Moran said, is an important strategy for preventing recurrent coronary events. Similarly, when you look at the patients who have multivessel coronary disease, they are a greater risk and derive a greater benefit. It's sort of intuitive. The more gunk you have in your arteries, the lower you lower the cholesterol, the more you stabilize that plaque and even regress it potentially, the greater benefit you have. And it extends outside the coronaries. So if you look at this slide in the upper right, I learned the term polyvascular disease from Dr. Bott, and this was studied in many trials, but this is in the Odyssey trial. You can see in the green line and the red line, those that have more atherosclerosis or higher risk derive greater benefit, and that benefit extends outside the coronaries as well in terms of stroke and major adverse limb events. But it's not just about the extensive coronary disease, it's about the acuity. You heard from Dr. Fuster that these are different. So patients with acute coronary syndromes and requiring acute coronary intervention are higher risk on the left, but importantly, they show an even different pattern of benefit. If you look on the right side, those with stable athero, they haven't had an event, it takes a lot of time to see the benefit of lipid lowering. On the left side of the slide, you can actually see the curves almost immediately diverge with a clear benefit by 6 months. These are different patients and they respond more acutely to LDL lowering, meaning when you put in the stent for an acute coronary syndrome, you should also be worrying about lowering the LDL acutely as well. Now, the dogma in lipid trials is it takes time to see benefit, but actually that's not true for acute coronary syndrome patients. In this analysis from PROVE-IT, when you look on the right side of this slide, there was a statistically significant benefit at 30 days. Now, a lot of people said, well, maybe this is inflammation, maybe this is the CRP lowering or pleiotropic effects, and it may be partially, but subsequent analyses like this from Steve Nichols have looked at plaque characteristics in acute coronary syndrome patients with non-statins. This is PCSK9 inhibitors, and you can see that there is positive remodeling, increased fibrous cap thickening, and reduction of that high-risk lipid core. So early LDL lowering is an intervention. And in fact, you might ask the question then, if these are plaque drugs, which they are, why not give them to everyone who comes with an acute coronary syndrome? They all have high-risk plaque. And in fact, we're studying that in this trial, Evolve-MI. Dr. Moran Bott on the executive committee. We've enrolled over 6,000 patients ahead of time, actually, and we'll answer that hypothesis prospectively. So what other tools do we have in the toolkit? Those are PCSK9s. The new kid on the block is bempedoic acid. This works upstream of statins. You can see on the left, it's not an HMG-CoA reductase inhibitor like statins. It's upstream. It lowers LDL, lowers CRP, some other effects like weight loss. The pivotal trial was presented here in 2023 called Clear Outcomes, reduces risk by about 15%, and is another tool for lowering LDL cholesterol. In fact, on this slide, you can see the effects of a variety of now therapies we have that lower LDL and have proven outcome benefit. One thing to note on this slide at the far left, increasing statin dose actually doesn't do much. You know, a lot of times I'm on service and someone comes in with an ACS and LDL of 40 and the residents will double it to 80. And I said, well, you've done almost nothing. In fact, you do far more by adding another agent in reducing LDL cholesterol. And I think we're into the era now of combination LDL lowering therapy to achieve goals early. Connie Hess and our group studied this in a small implementation study called Optimize PAD, showing that on the left, if you use early combination therapy, you can achieve very low LDLs within a month in blue versus just increasing the statin dose. And this was done all with commercial payers and insurance, no free drug here. So we can do that. Other things, inclisiran, small interfering RNA, also a type of PCSK9 inhibitor, if you will, working through a different mechanism. Long half-life, potent inhibition, so very exciting, particularly for patients that don't want to inject themselves or take pills every day. Outcomes data are coming. Orion 4 is a large pivotal trial. And then there are two more very exciting. So Victorian 2 Prevent, chaired by Dr. Moran, will answer the question for high-risk secondary prevention patients. And Victorian 1 Prevent is chaired by Dr. Bott and will answer the question for primary prevention patients. I don't have a lot of time to get into these, but I'll say there's even other modalities. In the upper left, gene editing. There are human trials ongoing now for gene editing for PCSK9 with very exciting results in oral PCSK9s, because we know not some patients will want pills, some will want injections. So the toolkit is getting bigger. But for primary prevention, unlike ACS, where you might say treat everyone, for primary prevention, it's a big population, and just treating based on a biomarker, particularly younger patients, may not be the best way to approach population health. And so there's a novel strategy being investigated. This is the Transform trial, chaired by Dr. Bott here, where rather than just treating a biomarker, using coronary CTA, AI algorithms to look at the stage and severity of disease and actually staging how low you're going to go with LDL and other interventions to personalize treatment for prevention in patients. All right, I'm just going to spend 2 minutes here on lipoprotein A, which is the new kid on the block for lipids, but isn't really the new kid on the block, because you can see it was first described in 1963. And Bob Eckel at our institution, past president of the AHA and ADA, says, I've been checking that for 30 years and everyone's just learning about it now. You can see LPA is a very proatherogenic particle. It's a subfraction of LDL. You can see in the middle of the slide. But it's not like LDL. This is genetically determined. You can see in babies on the right that by 15 months, your LPA is what it is, and it matches what your parents is. And so about 20% of the population has high LPA, genetically determined. And because it's genetically determined, it's heterogeneous depending on where you live. You can see that the density of high LPA is very heterogeneous, much less in Asia, more in Africa. In fact, African Americans have higher levels than non-African Americans in the US. So this is a genetic issue. Now, there's a whole host of studies I can't get into in terms of time, but there is very strong data that this is causal. This is not just observational data that high is worse than low for a myriad of outcomes, but actually Mendelian randomization data. And it's not just arterial issues, but calcific aortic stenosis and aortic aneurysm are tightly linked to LPA levels. And so these are all potentially therapeutic targets. Okay, so when to check? In Europe, they'd say everyone should get it, check once in their lifetime. The NLA has said that too. You might want to be more selective, but to me, if someone shows up at a young age with bad disease, they've got a bad family history, they show up with PAD, AS, or an aneurysm at a young age, they've got that malignant phenotype, polyvascular disease, they keep coming back even though their risk factors look controlled. If you're looking for the problem and you can't find it with traditional risk factors, it's almost always LPA. So check it. Because then the next question is, what do you do about it? Well, first of all, you have to educate. Smoking is bad. Smoking is really, really bad if you have high LPA. And I think it's really important for people to know and do all the other things they can to modify risk. They also should cascade test in their family. Lower LDL more. Think about PCSK9s. They lower LPA by about 20%. Treat all the other risk factors, colchicine, as you just heard about. Consider more potent antithrombotic therapy or even aspirin for primary prevention. There is apheresis for the sickest patients. But excitingly, I think you could enroll in a trial. And there are 3 outcomes trials ongoing. We'll probably get the first look at the efficacy of this mechanism sometime in the middle of next year from the Horizons trial. And there's going to be a ton of development here, so there's opportunities for people to enroll. All right, thank you very much, and I'll keep reading here.